Good afternoon. You are welcome to this afternoon presentation. My name is Victor Watinousu with Ghana Statistical Service. I will introduce each presenter and they have 10 minutes to present and 5 minutes for questions. We will have a leisure time for Q&A after all the presentations. Before we move into the presentation, I want to introduce the presenters so that we know what they are presenting on and their names. So I'll begin with the first person, Dr. Hong Tran from Vital Strategies. The title of her presentation is Evaluating Vietnam CR Health Link Pilot Towards Broader Implementation. So brief about the profile of Doc. Doc Hong Tran is the CRVS country manager for Vietnam under the Bloomberg Philanthropies Data for Health initiative, with over 5 years at Vital Strategies and a strong academic background as a public health lecturer and a researcher. She has a support effort to strengthen CRVS system in Vietnam, ensuring activities are country-led, technical, sound, and sustainable. She has conducted research on the completeness and reliability of mortality data, including the use of verbal autopsy methods for cause of death ascertainment. She also contributed to the development and evaluation of the current CR health linkage with CCOD models for community death in Vietnam, as well as the first National Vital Statistics Report. Let's see Dr. Tran by waving to the crowd. Thank you very much. Next to her is Miss Emily Asibori from Data for Health Initiative. The title of her presentation is A Hybrid Paper to Digital Verbal Autopsy Workflow for Strengthening Mortality Data Collection in Papua New Guinea. Emily Belinda Lesbori from Papua New Guinea is the program lead for ICD coding and coordinator for the verbal autopsy field team at the Data for Health Initiative. With a background in accounting and finance and HR management, her work in ICD coding and verbal autopsy has driven her focus on improving mortality data collection in rural PNG. She values the knowledge and experiences gained through participation in the CAT Initiative Research Program. Let's wave to the crowd, Miss Emily. Without wasting my time, I would like us to go straight to the presentation, and we start with Doug Hong Tran with Vital Strategies. Doug, 10 minutes.
Thank you very much. Yeah. Good afternoon, everyone. And thank you very much for joining the section this afternoon. So today I am pleased to present our work on the evaluation of the CR Healing pilots in Vietnam. This presentation is focused on the pilot implemented in one province in Vietnam and on what we learned from its result, its practical feasibility, and its potential for national scale-up. Next, please. Before I begin, I would like to sincerely thank you, our professional partner, Nghệ An Province, our colleagues from Ministry of Justice, Ministry of Health, and our technical team from Vital Strategy, and Bloomberg Philanthropy for funding the activity in Vietnam. As you know, you may know that in Vietnam, the National Action Plan on CRVS set ambitious targets for improving the death registration and mortality statistics in Vietnam. However, as of 2020, Vietnam had no officially published figure on the completeness rate of the death registration. In order to promote the implementation of the National Action Plan on CRVS, we are developing the model on the CR healing. The idea is basic come from the context situation when mortality data come from two sectors, Ministry of Justice through the civil registration system and the health sector through the health statistics software. However, the coordination on and data sharing between the two systems has been very limited. This creates a very important need for a routine and interoperable mechanism for mortality data exchange between the two sectors. That is the way when the CI handling model has been developed. Basically, it is a mortality exchange model developed jointly by Ministry of Justice and Ministry of Health in 2022 under the technical support from Vital Strategy Data for Health Initiative. Its goals is to improve the completeness and timeliness of the death registration managed by the Ministry of Justice, as well as mortality data managed by the Ministry of Health. And at the same time, it to enhance the consistency of the mortality statistic in Vietnam. The objective of this model is to establish an electronic and interoperable mechanism for routine mortality data exchange between the two sectors. So let's talk a little bit about the model, what CI Healing is. In this slide and next slide, I'm going to introduce about very briefly about the model. This is the short version of the business process map. There are two ways of the data exchange, one way from the health and the other way from the justice to health. So in a sense, the health sector and the justice sector automatically share the death data with each other every day in an electronic environment. The two software systems automatically match record case by case, and data interoperability will be done, matching will be done based on the national ID. Or in case there's no national ID for the case, it will be based on the four key variable, date of death, date of birth, sex, and address. So this slide is about the wave, the flow from health to CR. So the health system still do their routine work. They collect information about the death at the community in their catchment area, and then they're entering into the software, health statistics software, as you can see in the slide, and then it turns to the database with individual death. Here, the system health transfer to the Ministry of Justice system, and the data two system will make the data interoperability automatically to the other system. This is about from CR to health. Yeah, next slide. The CR to health. So the Ministry of Justice or CR officer, they do their own work about the death registration. So it is not that our model doesn't affect any routine activity. It is a complement, and it is something to support the work from each sector. So CR from the justice side, they register for the debt, and whatever they register from a day, they transfer the data automatically to the health sector, and the data will the data interoperability mechanism will be done automatically with the health system, so that the health staff will know about how many deaths occur in their catchment area, so that they continue to do their tasks, which are following up with the family to ask for the information on cause of death. For justice, when justice receive the information, the death from the health, they know about how many cases hasn't been registered. So that our process requests the justice officer to contact the family to encourage for the on-time registration. um, so overall, the model creates a practical two-way exchange that support the routine work of both sectors. And the model was first tested in 62 communes in 2023. And then it is piloted province-wide in Nghệ An province in 460 communes for 12 months, from April 2024 to March 2025. After 12-month implementation, we conduct an evaluation and focus on three main objectives to answer three questions. First is, what are the important results after 12-month implementation? It aligns with the first objective. Um, what or what how does the model benefit the health sector and the justice sector? For the second question is, were the process, software, training material, and technical support suitable? And the third question is the model feasible for routine continuation and national scale-up? We apply mixed method approach in this evaluation. For the quantitative components, we analyze the mortality data from the civil registration and health database from 2021 to 2024, so 4 years data. And we conducted online survey with the commune and district staff who involved in this study to understand more insight about how everything's going, what is the operational thing, and how suitable the operational thing. For the qualitative components, we conduct in-depth interview, focus group discussion, and expert consultation. The evaluation focused on completeness, timeliness, consistency, feasibility, and recommendation for national scale-up. Next slide, please. After do the data analysis, we found the result we found very positive result. In terms of direct outputs of the data exchange, the justice sector electronically share 11,674 registered death case to health sector. At the same time, the health sector transferred 6,335 unregistered death cases to the justice sector. Yeah. And by the end of the piloting, 80% of the unregistered death reported by health sector was registered by the Ministry of Justice, and only 20% remains unregistered, which may be due to the lag time for the registration. And we do the data analysis at the end of March 2025. So that is a result. Another very positive result comes out from this pilot, this evaluation is we found a substantial improvement on the completeness and timeliness when we see the data show that the completeness of death registrations increased from 59% to 91%. And the completeness of the mortality data recorded by health sector also increased from 36% to 88% in 2024. And timeliness of the death registration increasing. It's better, become better. The average lag time decreased from 70 days to 6.5 days at the end of the intervention. We've also found the intersectoral data consistency improve very substantially. The number of discrepancies in the total number of deaths between the health and justice sector decreased sharply. You can see like from the 8,100 cases to 1,000 cases in 2024. So it seems like 7 times, less. This shows that the two systems became much more aligned after the intervention, and it will improve the data quality of the mortality statistic. Regarding to, as I mentioned in earlier, we have another objective about how suitable of the operational thing, and the results show that regarding suitability, most staff found that the process convenient and easy to carry out, and the software was generally user-friendly, although we found some technical issues remains, such as slow reporting extraction, sometimes like a slow detecting of the case when entering the ID number of an on case, it takes a little time to find out if it is duplicated in the system. Training material was considered easy to understand, although a few respondents suggested that it should be shorter and simpler. And technical support was positively rated, and most issue was resolved within 1 day. So we're very happy to hear from the survey from 460 commune, the feedback both from justice and health to feedback about this. Next slide, please. Regarding to the feasibility, a big question about how feasibility this model, how feasibility of the sustaining the model and scaling up to other province or nationwide. Both quantitative and qualitative findings show strong perceived feasibility of both sustained implementation and future national scale-up. Almost all community health staff consider the model appropriate for their work, and the justice sector also show very strong support. Most participants support maintaining the model as a routine activity and recommend for another province. However, there are two challenges remain. We found that there's still a lack of formal from the quantitative and qualitative. The people said that if we scale this model nationwide, we need to have a formal legal guidelines about the routine data sharing data exchange between the health and justice. And one remaining challenge is the difficulty in cost of debt ascertainment. Yeah, they found. We come up with one of the things we are asking the respondent as well as the dudes during the data analysis is what is recommended condition for national scale up. This section synthesize finding from both quantitative and qualitative as well as feedback from expert consultation and organized into the 5 domain to inform the future action for national scale up, which focus on first about to make sure the formal legal guideline governing routine data exchange. The second is preparing for human resources and infrastructure. Third is the completion of the software function in both sectors. Fourthly, strengthening the training, especially on cost of debt collection and ascertainment. And finally, strengthening monitoring and technical support mechanism if we want to scale up nationwide. In conclusion, the CR Healing model in Nghệ An province resulted in substantial improvement in completeness, timeliness of death registration and mortality data, as well as consistencies of the death data in Vietnam, which enabling more accurate national mortality statistics. The model is feasible since it can be well integrated into the routine workflow, offering a practical pathway for national expansion. Future efforts should address legal gap, strengthening software function, enhance training and support, and improve cost of data collection. Thank you very much for for listening.
Thank you very much, Dr. Tran, for your nice presentation. At this point, I give opportunity to participants here in the room for one question. He who laugh last, laugh best, because we have one presenter not around.
Thank
We
you,
are
Dr.
using
Tran.
that time. Okay, please, question.
Mr. Dr. Chan, you have a good presentation, and I have several questions about the unregistered disease. Have you ever evaluated what's the characteristics of this disease? And the second question is, target on this unregistered disease, do you have any policy implications to them?
Yeah, very good questions. We have already discussed within the team about that, and we will do further analysis. I think it's absolutely we need to do further analysis on the 20% about 1,000 unregistered debt. Actually, 1,122 unregistered debt at that time. Now it may be less than because from the March 2025 until now, they may have already been registered. But your recommendation, your question is good. Yeah, thank you very much. I think it needs to be analyzed further at the point of data analysis. But at that time, we just do this as an overall evaluation to show the government about the effectiveness of this model and to recommend for the national scale up. And the very good news that this year, the beginning of 2026, Ministry of Justice is very exciting to hear from the result, and they are also involved in the supervisorship. Sometimes they decide to work with Ministry of Health and to decide to make this national scale up. Yeah.
Thank you very much. Can we reserve the next questions when we get to the end of? Or okay, please.
You. Yeah, thank you. I want to ask a very simple question actually. Did you face any challenge in developing Vietnam CR Health pilot, and how did you address them? Very, yeah, like a challenge in whatever scope.
The question is about is there any challenge? Yeah, the challenge come. Some of there are a lot of challenge, but we step by step we overcome some. I will talk about this, and maybe Châu, my colleagues working with me, can complement. The challenge come from very beginning of what we have done when we managed to make Ministry of Health and Ministry of Justice can talk, can work with each other. Usually before there are two parallel systems, but yes, silo separately, and they don't interoperability with each other. So we see that the benefit of making the two system interoperable, and we pursue up them, and we talk at the time. It's very lucky that we are based on the national action plan on CRVS. So we are vital strategy team. We come to work with Ministry of Health and saying that yes, Vietnam didn't have a number of the completeness rate, and we Ministry of Justice still saying that we are the completeness rate of that is about 60%. They just estimate like a very qualitative in number, but they have no sources of information to calculate that. And that is the way that we are based on. We are persuade them to work on the work this, and we are persuade them if they work with Ministry of Health. Maybe they are because the fact that Ministry of Health in our country have a network of the village health worker or the collaborator, so they can come to very like a mountainous area or vulnerable group. They know about who died in their community, and they collect. So that is the limitation of the. Usually, the justice system is a passive system. They just collect the information about what people come to them to register. But health sector, like a active system, they come to the commune to collect information, and we show them that yes, the commune health station can bring some more data, and you can increase the completeness of the debt registration and tag to the National Action Plan on CRVS. So, yeah. And yeah, there are also some other challenges about the cause of death, the methodology to collect the thing cause of death. But we figure out in another pilot. We separate it in another pilot. So this pilot is about make sure the number of death, the consistency of the number of death between justice and health. Our another model on community cause of death presented by Châu just before my presentation is about make sure the accuracy, improve the accuracy of the cause of death in the community. Yeah.
Thank you very much, Dr. Tran. Let's move to our next presenter, Miss Emily Asibori.
Hello.
Hello. So, colleagues online, when the presenters are done, we'll give the opportunity to you to ask questions. So, we will have 15 minutes for extra questions. So, please, let's hold on. Thank you very much.
It's Emily now. Okay, I thought it's Amilcar. Okay.
Emily.
Thank you. I have already been introduced, so I'll just go straight into my introduction. Um, well, my title is a bit interesting because I know a lot of people are moving from paper to digital, and I am actually asking to incorporate paper-based again. In a setting like Papua New Guinea, I feel that this is necessary because we have about 80% of our population living in rural areas, and determining causes of death remains very challenging. We have had verbal autopsy used by institutions like the Medical Research Institute, but not as a data collection, death mortality collection tool. It was used for specific projects that they targeted at, like malaria. So recently, the PNG Data for Health Initiative introduced a smart verbal autopsy as a trial to use as a routine data collection tool at the community level, because a lot of our deaths occur in the communities and we don't have medical certification for those deaths. Although initially this smart verbal autopsy improved data collection, we have realized that coverage has declined due to infrastructure, workforce, and safety challenges we face at the community level. The purpose of my research is to evaluate the VA model that should combine, or that is trying to combine paper-based and a tablet-based smart VA to improve mortality surveillance at the community level. The study seeks to determine whether this approach can ensure continuity of data collection despite all the challenges we face in infrastructure and the high turnover rate of health workers and the incompleteness of causes of death data collection through the VA that we are currently rolling out. Next. The methods I am using to collect this data is one semi-structured interviews. I am doing this both in person and remotely where I can't reach the interviewers. I am sending out emailed questionnaires, in-depth interviews, and focus group discussions. If feasible, I intend to do site visits to our rural communities as well. For data analysis, I will be using thematic data analysis. I'll also use NVivo if I can to find out to analyze the data, coding and team developments of the interviews, and also, of course, triangulation, because triangulating it, I will have analyze the data from various angles to actually find out if this tool is going to be feasible. I expect to find the study aims to confirm the operational challenges such as difficult access to remote communities, transport limitation, and the workload for our CHWs, community health workers. Two, technical barriers such as poor internet connectivity and unreliable or no power supply to charge the tablet devices, and tablet malfunctions, because a lot of our remote areas, when we don't have electricity, we use generators to charge tablet devices, which damage tablet battery life. So we find that the cost of replacing tablets quite expensive. And three, human resource constraints, limited training and digital literacy. Although our health workers can do the jobs that they are trained for, using the tablet to do verbal autopsies are also challenges for them. So we need to address that gap as well. Staffing turnover or inconsistent supervision, because when we train the health workers in a location and they move to another location, we have to train new people to do verbal autopsies. So we see that it's costly to be training people, and when they relocate to other work locations, we have to train new people again. So we need to look at these community level factors such as cultural sensitivities and beliefs around that also limit people from taking part or answering VA questions. And this study is expected to show that a digital only VA system faces major challenges in rural areas due to infrastructure, workforce, and cultural barriers limiting data completeness. The study is likely to highlight that a hybrid paper to digital approach is a more practical solution to improve mortality coverage in a place like Papua New Guinea. The findings will inform practical evidence-based recommendation to strengthen mortality data collection and support policy and contribute to improve CRVS in the country as a whole. My key recommendations: I opt to adopt our hybrid VA system in the country. Currently, we have a guidance document for VA that's been drafted. Me and my work colleagues are drafting this, so I plan to include this. Secondly, to strengthen system and capacity. VA policy draft has been done, and it's currently in the draft form, and we are having it edited, so it will also include this. And to develop clear protocols and contextualized training manuals for PNG context. A draft of this has also been completed. So we are working towards having this also included. And then also to have our community be aware of the benefits of having VA done at the community level so that causes of death can be found. My way forward, after this, I intend to complete the data collection and have the analysis done to disseminate the information from this research. I intend to develop fact sheets from the findings, and this can be presented at the National Burden of Disease Committee meeting, which the Data for Health Initiative coordinates for all major stakeholders in the country, which I am a part of that committee. So it's headed by the health secretary, and I am happy to have this presented there for policy decisions to be made. That brings me to the end of my presentation. Thank you. Because without reliable data on how people die, we cannot truly improve how people live. And this research offers a practical path to make every death count in Papua New Guinea. Thank you.
That's a wonderful presentation from our presenters. At this point, we will invite questions. Colleagues online, please, can you type your question? Please start with your name so that we can mention your name and the question that you are asking. Then the presenters are here and ready to respond to the questions. In the meantime, those in person are waiting for your questions, please. Thank you. Yes, we have 15 minutes to ask, so please feel free to ask as many as you can. Okay.
Thank you for your presentation, Emily. Miando from Indonesia. So we are neighbors, and as you see, we have many varieties in Indonesia as well. And your condition is also similar to what Papua's in our one of our province, Papua's is having right now. I would like to know your recommendations here to have a hybrid models for VA. Is this a temporary solutions or is just an interim solutions until you have better connectivity, access, and everything? If yes, what is the minimum requirement for you to move from the hybrid models to fully digitalized? Or what do you have in mind right now? So yeah, we would like to learn from it. Thank you.
Thank you. Currently in Papua New Guinea, having internet connectivity in the villages and in the rural communities is a very big struggle. In my village, when I get to the village for holidays and I need to call into town, I walk around with my mobile, trying to find a spot where I can catch the network. So we say fishing for network. And so we walk around with the tablets. When we find a spot, we stand there, and that becomes your telephone booth for however long you're going to be in a remote area. And this is also the same challenge our VA interviewers face out there. When they collect the data, they enter it into Kobo, and they have to upload. They have to get to certain places in the community. Either they climb up the mountain, they climb up a tree, they pedal out in a canoe. They have to do something where to find coverage to upload the data that they collect. So it's a big challenge. I can't actually give a timeline on when we should transition completely to the digital-based VA. But as it is, because of these challenges, we have our data collection seems to be regressing. That's why I am suggesting to have a hybrid model where we have the paper-based. People out in the communities can collect that information on paper, and then they can get into the districts where they can charge the tablets, complete and upload it. So I can give a timeline on when we intend to move to a digital only. Thank you.
Thank you very much. Do you want to add something? Okay.
I would like to learn from your country. So it seems that 80% of the population live in rural area, and so it means that for the community concept that you apply polyverbal autopsy, and how it is now a national or just one area.
Thank you. Currently, we are not. This is not implemented in the country, whole country. We only have selected sites we are trialing at. Selected sites in the country, about 5 provinces and 7 districts that are trialing it. And then this is where we are seeing the difficulties. We have an evaluation coming up once we evaluate, and then we can see how feasible it is to roll it out to the whole country. Thank you.
Okay, let me take the next two. Then, so please.
Okay.
Then.
So actually, my question also follow his question as well. It actually the study not yet to finish, so you not yet to have some kind of defense in the committee. So I will let that question later. But in my experience, when we do the VA, we use the tablet. In some time, I remember it can support you still use the offline, so you don't need some kind of paper base. So whenever you can get access, so this could be the upload that kind of information. You don't need any kind of paper, and we still have the measure the how long that it take for each question, and make sure the interviewer go through all of the question. Only limitation that we don't know where the interview take place, because if you have the internet, then we can satellite and understand GPS in identify where you are. So that's per my understanding. So you can consider about the still keep the electronic one, but you can accept for the two option, because the per our experience in my country and in any kind of the discussion, the reviewer always ask, because we do for the two option. So what should be very clear criteria, because people tend to use the paper base, because it can get more, because I can have the fee for the data entry, or I can delay the work later. So it's very flexible. So should be very careful with the protect with the reviewer committee. Thank you.
Thank you very much. Let's get the next question.
Yeah, so my question goes to the doctor. But since you mentioned curiosity with PNG, I'll just mention a few things to start off the base of the question before I ask the question. Now, for Papua New Guinea, we have isolated systems. We have EHNIS, which is a death registration system in the health system. And then we have civil registration, which is a Java-based platform on HTTP web. And so my curiosity in your presentation was there was a little bubble you put in the middle to connect the two systems in Vietnam, and how your data is being cross-referenced to reduce mistakes in data records. I was interested in understanding what platform you are using for the interoperability. I hope it's not too technical for you to answer for me.
For Vietnam. For the data interoperability, when we do the pilots, we just make the two data system to work with each other from the CR software. Basically, let's say CR software, we develop a additional function. And from the health sector also we create an additional function to make the two software to link to each other to receive the data. So basically, but when we do the national scale up, we need to, the two systems need to pass some very technical and like a data security and everything. And in Vietnam now, right now, the digitalization is very going very fast, and the government requires any system to work at national level. They need to pass into the national data portal. So there should be another play. It's simple. Let's another play that the health need to connect with and have to pass the different technical condition to allow the data exchange. And the similar thing happened with the Ministry of Justice, I mean the CR software. So they need to go through the national database, how to say, national portal, and yeah, and what as where the data can do the interoperability nationwide.
Thank you very much. So when a system is having that national portal, it serves as a data pipeline that institutions can tap for that interoperability system. Thank you. Fortunately, unfortunately, our third presenter is online and he is willing to present. He is in the person of Mr. Amelka Magazo, an anthropologist and a PhD candidate in epidemiology and public health at the Swiss Tropical and Public Health Institute, Swiss TPH. Over the past 3 years, his research has focused on the performance of mortality surveillance system in Mozambique, with a particular focus on understanding the perspectives of community and health system decision makers. Our presenter is ready. Please, over.
Thank you. Thank you so much. Hello, everyone. So, can I share my screen now? Can I share my presentation?
Sure. Are you loaded?
Yes. So I'm trying to share. Can you see my presentation now?
No. Kindly share. Yes, we can see now. Thank you.
Okay, thank you so much. Okay, so hello everyone one more time. So I was supposed to be in Bangkok today, but I had some issues with my old itinerary, and also the organization thought that I was in Mozambique, but I was in Switzerland. I'm in Switzerland, and then, yeah, this one one of the main reasons, but it's okay for me to present online as well. So thank you for this opportunity. So the title of this presentation is very on purpose on what we are discussing. I mean, what we are seeing in the previous presentation. That's why we entitled this as Mozambique is not different. The first thing is because we saw in literature and then also all the guidelines of the WHO and vital strategy, we were seeing that most of the problem that most of those low-income countries are facing are very similar, and that's why we thought like, okay, yeah, this situation is not unique, for example, for Mozambique, and then we need to address way trying to understand how the system works and how can we improve. That's why we say understanding the architecture and the function of mortality information system through a participatory system approach. So in Mozambique, before I start, I would like to acknowledge all the participants from this study, also the institution who accept to participate, the Manisa Health Resource Center in Mozambique, who support with the facility and also some resource to do the workshop, and Swiss Tropical and Public Health Institute, who accept me as a PhD student, also the Swiss government will give me the scholarship. So, as many of us know, in many middle and low-income country, the availability of mortality data is limited. that's to immature civil registration system, as many of our colleagues present here. And then the difficult to collect and record mortality data is most of those countries are facing, as we can see in this map. And particularly for mortality occurring in a community, or we can call community death, which is very difficult to collect and to report those kind of information. And in Mozambique in particular, this problem is not unique, and the problem is exacerbated by high mortality rate, for example, and the low completeness of mortality registration. So and then the limited of availability of this data fail to support, for example, the police decision effectively. So that's why we think that if we are not collecting mortality data, if we are having a very low completeness of mortality data, we will not be able to support the decision, inform and support the decision. So that's why we designed this study, which aimed to examine the information data, the operational flow of mortality registration system, and the role in recording and reporting mortality in cause of death statistics in Mozambique. So for this study, we apply system thinking approach as a tool to understand, for example, holistic understanding and analyzing, and holistic understanding, analyzing, and intervene in complex system by focus on interconnected and feedback loop and underlying structure rather than consider a system or as an isolated part. So for this particular study, we apply 4 different stages, which is understand the context, mapping the flow, analyzing the map, and then also design the social network analysis. For each of these setting, essentially we starting with the data collection in the field. We carry out the field work where we collect the information through document review on the Ministry of Health Civil Registration System and all the health facility in the district that we was using as a case study in Manisa district. And we also apply in a key informant interview with some key authors at the Ministry of Health and Civil Registration System at the province and then also the district level to understand the context. By using the information from this phase, we designed the process mapping, which was the mapping on how the system work in terms of the flow of information. So, and the resulting map of this information from the interview and document review was subsequently presented, discussed, and validated in a district participatory workshop with the key stakeholder in the district. And this discussion was very important to see some gaps that we was facing, that we was describing in the process mapping, and also those participants in the workshop, which was the key author at the civil registration system and the health facility service, they was very important participants to make sure that we can address the map as it work and in the real world, for example. So based on this map, we also collected the workshop, we collect information and then we use this information to design an Excel sheet with the information on the connectivity between different stakeholders. And we use this to do the social network analysis, which you are presenting. So going more to the result, we see that this is the full map on the mortality information system in Manisa district. We bring here Manisa district as a case study, but in a country, we have kind of similarity and difference. But in Manisa district is one scenario that we feel that is important to bring in this discussion. And of course, we also start start this study in Manisa district and also another district, but for this specific, we focus on Manisa district. So in this process mapping, we can see all the stakeholders involved on mortality notification, registration, and report, and how they work. Basically, we can start seeing like the first stakeholder is family. We highlight this because we saw that family, they have a very important role and they connect with more than 5 stakeholders, for example, to when the death happen, even in the community or in their facility, they need to connect with the different stakeholders to make sure that from the notification to the registration, all the process will flow with no problem. And then the family, they have this um, connection, and the role of them is very important to make sure that the debt will be finally registered. The second thing that we identify is many data set in the just in the health facility, for example, where they all collect mortality information. We have data set from the system they call SISMA, which is DHS2, and MD. MGDH, which is mortality data set for hospital death, just hospital death, but is not present in all facilities. It's just on facility where they have system and capacity. In the previous presentation was discussing about the digitalization and capacity on tools and the connection, internet, for example. Or this is not all a facility in Mozambique that have this kind of condition, and also statistics database in the hospital. Another thing that we want to highlight is the interoperability between the health system and civil registration system presenting in this district in specific. And also we highlight this interoperability is also important, but they face some problem because of the poor internet connection, poor training of some technician, and also poor coding of cause of death. And this interoperability, of course, did help to connect the information from one source to another, because most of the death in the civil registration system coming from the hospital, and also in the civil registration system, they just death just coming from the community, which is not present in the hospital database, for example. So based on this information from the social network, from the process mapping and the workshop, we designed the social network analysis. More specifically, we observe with the social network analysis how the different actors in the network interact with each other regarding this, all the steps as the notification, registration, and the mortality or death report at, for example, National Institute of Statistics, for example. And we bring here that the network is more family-centered, and the system rely on family to physically carry out the documents in physical between different disconnected nodes, which we can call different actors. We can see, for example, the family need to communicate with the community leader, with district government, with the cemetery, depend on the cause, the type of death, also with the police, and for sure with the hospital and the civil register in the district. If the family skip one of these different actor, most of time the death will not be registered. So this is very heavy in the family. And of course, we saw that the network in this case is the density of network is not is low, we can consider, but it's very high in terms of intermediation, or we can call betweeners, as we can see in betweeners like 40, means that between is a measure who sit in the, so we can see family as this high between it on 47.5, or it means most of the communication or interaction in this network is very centered on the family. So without family action, the death cannot be registered. in the two streams, like health facility and civil registration, they end up at the civil health of statistic annual report. They at the National Institute of Minister of Health and National Institute of Statistics, they use this information and report the annual vital statistic report. So then, at the end, we end up saying that there's the system is fragmented, yes, and then also is divided by these two streams, air facility and civil registration. And we also face kind of weak interoperability, but at least they have kind of interoperability, but still paper-based and off, because family need to go to different actors to guarantee registration. And also all this problem they bring us to a low completeness or decline completeness. Consider that in the country the completeness of mortality information in 2023 was 11.4, and then in 2024 it declined to 10 point something, 10.5 I think see now. And also seeing that the family is the center of this, the entire network feel like they expect family to do most of the activity to make sure that the death will be registered. The family must do, they need to report the death. The family need to complete the registration. But also all this problem became a huge problem in the entire system because of the distance for the family, cost on the traveling to the civil station or to the hospital or to the main city to go to all this different networking, and also the moment of pain of loss. This make them to drop off and not specifically register mortality that happen in the community. And so the interoperability, of course, help, but the problem remain on the reinforcing this loop on family being very important, but also the interoperability should work more effectively if the connection and all the tools important for the interoperability work properly. But this is not the case for kind of this district in particular, where in the main village the connection is allowed, but not every day. Is what of the one of the participants just mentioned this, and then this also create this kind of problem to connect from one system subsystem to another. In conclusion, Mozambique registration system is family-based, and it's flipped into two parallel streams as health facility, where they register facility statistic for all facility debt, and civil registration stream, where they register facility debt and also community debt together in one unit, and then they connect each other from this interoperability. And all the legal competence still requires the family to go in person and to both subsystem to make sure, confirm the debt, and also finalize the registration. So, and then the lack of coordination between these two, in particular in the district where or village where the connection is not good, the problem start where some debt will not be linked with the main system, and then some debt end up with no registration, and that's why we have this low completeness and timeliness of mortality. Registration could remain very, very, very poor. This is all that I want to present, and then this is one photo of the participatory workshop that we did in Manisa district when I was there, and with the people, actors from the civil registration system in the district, health facility, and also in the district, and some actors from the provincial level that work on the civil registration system in the National Institute of Statistics. Thank you so much.
Thank you very much, Mr. Amako. I hope I got your name right.
Magaso, no problem.
Yes. Thank you very much. We nearly missed this interesting presentation, but we appreciate your time joining. Colleagues, I will take one question, if any, for Mr. Makaso. Otherwise, the rest, we can email our questions to the organizers so that we can looking at our time. Please, one question, if any. Yes.
Thank you. Thank you for presenting that, and I appreciate the fragmentation between the health sector and the civil registration, and also the family-centered nature of registration. But I was just wondering about within the health sector, did you also face challenges of fragmentation of mortality reporting by programs, and were you able to solve for that, or was that not an issue in your context? Thank you.
Okay. Thank you so much. This is very important presentation because now this one was the first exploratory study on this field, but and now I'm doing the second one where we are trying to understand all this fragmentation, whether in the health sector and or the entire ecosystem of mortality registration and including mortality surveillance system in the country. So what we know now is that at the health sector, there is a lot. I mean, I think I show in the process mapping that we have more than 3 or 4 different data set just in the hospital. This one is not a national hospital or provincial hospital. This one was the rural hospital in the one rural district, but they have 3 or 4 different data sets. So the fragmentation starts in the hospital because each disease surveillance, for example, they create one specific surveillance subsystem to collect mortality, for example, on malaria. And then the hospital, the main hospital also, they register in Excel base, a small database on hospital data as well. But the DHIS2, which is the main system and the national system, they also are collecting mortality information. And then we think that all those different subsystems in the unique system, they increase this we can say this as multiple database where also they increase the fragmentation in the main system, and then also they make the system not connected each other. I mean, they are not very connected. The communication is not very high, and also the interoperability is not between the all system or subsystem that exist in the country or in the facility, but is between the main system at the facility, which is DHIS2, and another system apart in the civil station system.
Thank you very much. At this point, can we clap for our presenters?
Thank you so much.
As we wrap up this session, one thing is clear, and the key terms that run through: interoperability, data portal, online portal, data pipeline. What does this all means? Every contribution made today brings us closer and also brings a stronger system to our various institutions and the country that we live. The exchange of ideas here reflects not just expertise, but a shared commitment in progress. So let's keep this in mind. And as we live here, let's keep the conversation going so that we encourage you to exchange contacts, informations. And I want to sincerely thank our wonderful speakers on behalf of the organizers and my lead moderator here, all of you, for such engaging session. So let us encourage or give everyone at least one round of applause again so that we close our session. Thank you very much. Colleagues online, your questions are welcome through our mails. Thank you.